Hello, everyone. Welcome back to another episode of the Dental Trade Alliance podcast. My name is Kevin Henry. I'm not only honored to be the host of the DTA podcast, but also honored to be the editor in chief for drbicuspid.com. I'm very anxious to get into a topic today with two gentlemen. I'm going to introduce them right now. First, we have Dr. Tom Schwieterman, who is the Vice President of Clinical Affairs and the Chief Medical Officer at Midmark. Dr. Tom, good to see you today.
Hey, excited to be here. Should be good.
And then we also have Ted Kehagias, who is the chairman of the board for the Dental Trade Alliance, as well as the vice president of sales on the dental side for Midmark. Ted, always good to see you as well.
Yeah, likewise, Kevin. Really, thank you for having us on this podcast.
Absolutely. I appreciate you both taking the time. We're going to talk today about medical dental integration. So you're going to hear the term MDI thrown around quite a bit. That is what we're talking about today. And this is something that the Dental Trade Alliance has been working very steadfastly on behind the scenes in front of a lot of people. But I wanted to make sure that everybody understood this about what DTA is doing with medical dental integration. It is a benefit of the membership. It's also something that they are not taking a stance on this, but they are looking at providing insight into how the dental industry could be impacted by medical dental integration in the near and far future. So Dr. Tom, I'm going to start off with you today as we talk about MDI. And in your position as that Vice President of Clinical Affairs and Chief Medical Officer for Midmark, you've watched MDI very closely. You become the medicine and dental coming together, becoming more aligned. What do you see as the main reasons for this alignment?
Kevin, I've been watching this for about 10 years. I remember my CEO asked me to do a report 10 years ago on where this situation stands between medical dental integration. And I remember the research back then was really interesting because it showed an absolute clinical relationship between the oral cavity and the rest of systemic health, that the doctors and clinicians knew that this was going on. What was missing at that time is the causal relationship. Is there a reason behind it? And since that time, 10 years ago till today, there's been an enormous amount of research on the basis of disease. And it kind of stems from this concept of inflammation in the body. And the pandemic just accelerated this to a great extent because if you look at the COVID virus, it's a very much an immunological kind of event. And most of us understood that, unfortunately, from the tragedy we suffered through. But this inflammatory basis of disease sort of brought to the fore why this causal relationship exists, because of the oral cavity and the periodontal condition is extremely inflammatory in nature from a disease scenario. And unfortunately, we're kind of suffering from our own pandemic of sorts of periodontitis in this country. So finally, we got this sort of relationship between the oral cavity and the rest of systemic health began to make more sense. And so why do we need to pay so close attention to this oral cavity as part of our systemic management? So I think the reason these two things are coming together kind of forms its basis around the clinical arguments. What we're starting to see is a more economic sort of argument behind it. Is there a relationship between these two where treating one reduces the cost of the other? Treating the periodontal condition, does that reduce diabetic costs? And those statistics are just coming in. And my sense is in the next year or two, we're going to see a whole lot of economic data that's going to put both the clinical and financial arguments together to make this a much more powerful reason for the integration to occur.
And Ted, I know whenever you came on board as the chairman of the board for the Dental Trade Alliance, that MDI was one of the key tenets, really, that under your leadership. And I'm just wondering, what is it that you see about MDI that is so important to the dental industry and to Dental Trade Alliance as well?
Yeah, sure, Kevin. That's a great question. So one of the things that we wanted to make sure that we provided to our membership is really value. And I think about when we started this initiative around medical dental integration, what was important as we partnered with a firm, and the firm that we partnered with is Charm Economics. They're a leading healthcare data economics company. They consult specifically for companies like ours, or really member companies like ours. What Charm has been able to do is provide us with the insights. And as you mentioned, DTA is not for or against MDI. We are just specifically just providing guidance and insights so member companies can make decisions based on the outcomes that we see transforming with MDI. I kind of like it to this, Kevin. We just went through a pandemic just 4 years ago. And if you think back about 12 years ago, we went through this medical device tax. Think about this for a second. if we had a playbook for both of those conditions that were thrust upon us without any real knowledge, we would have been able to make decisions that were more confident and faster as a result if we had a playbook. Essentially, this is what we're doing. We see that MDI will enter the dental industry, and we just want to make sure that member companies are prepared to make those necessary business adjustments to take advantage of the growth, maybe even some of the complexities and challenges that MDI may present.
And speaking of that, I'm curious, can you share kind of at a high level what you're seeing maybe on the supply side of the dental industry that should be kept under close watch, the DTA is really keeping a close watch on?
Yeah, absolutely. I mean, really what we want to make sure that, the entire membership is really looking at the reform and expansion of MDI. There's a couple of key components to this that most member companies should really key in on. We know that oral systemic health is undeniable, right? I mean, we're already leveraging that. Secondly, we look at the rising cost of dental care is about 20% over the last decade, and that's really important. And why? Another reason why this is happening. Also, follow what we start to see with CMS. CMS is a key contributor and maybe a stakeholder in MDI. For example, in 2021, the House of Representatives passed a dental benefit in H.R. 3. In 2021, the first dental officer was elected, Natalia Chalmers, who's a pediatric dentist. And right now in 2023, CMS added 25 new dental surgical codes to Medicare. So as we follow along what's happening with CMS, I mean, this really will kind of be the crumbs that will be dropped to let us know how quickly this will happen and then how we would adapt to it. And by the way, all this information can be found on the dentaltradealliance.org website. If anyone want to have the resource, it's available on there as a resource today.
That's a great point, and I'm going to make sure that people have a link to that in the show notes, so it's going to be really easy to find wherever you're getting this podcast. You can click on the show notes and be taken directly to that. So great point, Ted. Thank you very much. Gentlemen, as I mentioned in your bios, both of you are affiliated with Midmark, and I'm curious to both one of you, whoever wants to answer this, what does Midmark see as unmet needs at the point of care should MDI advance and become widespread as a preferred care model?
Yeah, I'll jump on that if you don't mind, Kevin. I think there's a real interesting dynamic going on with respect to bringing these two disciplines closely together. There's some products you have to bring to market that are brand new to world, new concepts that need FDA approval for brand new sensors or the like. Then there's another category where you have existing technologies that are absolutely applicable and usable in the market today, but just haven't reached the other side of the market that they may be applicable for now. So I think that's more the case in this scenario where that we have most of the tools we're going to need in order to bring some of these unmet needs to the dental operatory. For instance, if you're doing blood pressure at the point of care, that's a very traditional medical diagnostic tool. It just needs to be brought more proactively and more basically to the operatory as well. Then you have all the genomic studies and the point of care testing with respect to hemoglobin A1Cs for diabetes. You've got some biomarkers in the oral cavity and the systemic health that can be brought over to the operatory as well. Likewise, on the dental side, there are things being done in that dental operatory that could be done just as effectively at the point of care for the medical care. As an example, we have the American Academy of Pediatrics has long recommended the application of fluoride varnish in the well child visit exam. And that's not a dominant use case that's going on today, but we're seeing increased interest in bringing that fluoride application to the point of care. So what we see going forward is that there are existing technologies that need to be brought forth so that they are more applicable to the other discipline. We, of course, are looking very carefully at the point of care as far as what can we do with patient positioning so that we can have maybe a hybrid location. What can we do with cross-disciplinary education to make sure that one side of the equation understands a little bit more about the other? A couple examples of what we're seeing in the industry today are kind of interesting. We visited both Kaiser and PDS Health in the last couple of years. And at the Kaiser model is sort of a unique model where they actually have a fairly established and broad-based dental offering in their Pacific Northwest. and they're really focused on care gap closures. So whenever they see a patient for the oral health domain, they want to make sure that that patient's getting the right care gap closures, that being like immunizations, vaccinations, mammograms, prostate exams, colonoscopies. They know that there's an opportunity at the point of care for the dental provider to sort of proactively manage that. And those are economic home runs, because if you have a patient who gets those things done, the long-term costs are fairly well understood to be positive. That's a really sort of a kind of bringing the dental provider into the holistic care from separate geographic locations. When we visited PDS Health in Henderson in Arizona, they brought these two disciplines under the same roof. And I've been there a couple times now, and it's fascinating to watch the maturation. At the beginning of it all, they were located at the same location, but they didn't do a whole lot of cross discussion. They did share the same Epic database, but the last time I visited, there was a lot more sort of collaborative spirit between the oral health team and the medical team. For instance, if somebody on the dental side had an elevated blood pressure, they didn't let the patient go home and say, come back. They walked them across the aisle and had them go to the medical side to have this more thoroughly evaluated. And on the medical side, if they saw a patient with diabetes and they did a quick oral exam and said, hey, your dentition doesn't look quite healthy, they proactively had one of the hygienists or one of the oral health providers proactively do a quick assessment to say you're going to need something done. So I think what I'm starting to understand here from this dynamic is that it takes a bit for the cultural phenomenon to settle in for these two disciplines to sort of share a holistic mindset around the patient management. But once it sets in, it's extremely powerful. What PDS also told us is the care acceptance on the dental side is significantly higher when it comes from the medical side of the community. And I experienced this personally. I was invited to go to the PDS Health national meeting, and I was given a salivary study that determined the biomarker in my mouth. And to my disappointment, I got a fairly advanced marker, which indicated I have some periodontal condition going on in my mouth. And when I saw that, it concerned me greatly because I do have a family history of heart disease. The first visit I did was to go to the dental provider. I didn't go to my doctor. I went to the dentist. And I've spent more in the last 6 months with my dental provider than I have in the last 10 years. I spent 3 hours with a dental hygienist, and I've had a significant amount of oral work done to help prevent that sort of biomarker from getting any worse. And so I brought this for my dental team, and they were extremely interested in the fact that I was coming to them for my holistic health just as much as I was for my holistic care. So I think there's opportunities kind of wrapped up into this around care acceptance, around collaborative spirit, patient experience, cost optimization. There's just a whole lot of interesting nuggets. So we see unmet needs more so in the category of bringing some of these disciplinary activities across the aisle.
Got anything to add?
Now, really just to bring it down to layman's terms, Kevin, in May, we had a chance to listen to Dr. Natalia Chalmers, again, Chief Dental Officer for CMS. And that was kind of a conduit for us to walk on the Hill and meet with our legislators, congressmen, et cetera, and really appeal the fact that by mitigating oral health, we benefit overall health. And for most of the congressmen really didn't understand the link. It was really simple. The same plaque that's found on our teeth is the same plaque that's found in our arteries. And that link is exactly the same. And that to me really just resonated with them to really understand that there are unique benefits of being able to mitigate inflammation in the mouth. As Dr. Tom mentioned, periodontal disease has a higher success rate with surgical procedures in the body. So Dr. Tom's spot on. I mean, he really has done a great job for us, just really learning about the implications, but more importantly, how can companies then help practitioners be more proactive and be able to see patients to benefit their overall outcome, not just their oral outcome.
Kevin, if I could add a little bit, Dr. Chalmers has been at a couple conferences that I've attended, and it should be noted that she has a PhD in microbiology, and I don't think that's an accident. Her understanding of this, pathophysiology of inflammation is just, she knows it as a PhD doctor. So I think there's a depth of understanding at the CMS that there's something here. There's something that needs to be progressed towards. in order to help deliver a better care experience and a better clinical outcome at lower costs. There's a disproportionate amount of this cost burden that happens in the underserved patient population, specifically Medicaid and some of minorities. And CMS is extremely attentive to that. And so I think the Medicaid side of the equation is looking very closely at whether they should be extending oral health benefits to the entire population of Medicaid beneficiaries, not just children. And I know there's a bill on the Hill right now. I think the economics are going to come back fairly positive on that it doesn't make sense to wait for the dialysis or wait for the cardiovascular bypass or wait for the stroke. If you get ahead of that and you can reduce that by 10 or 20%, those economics are extremely powerful because those end result events that are devastating to the health of a patient are extremely costly to the Medicaid system. And your listeners may not realize that Medicaid is usually, if not almost always, the top budget item for states in this country. So a 30% reduction in periodontal prenatal birth, treating mothers with periodontal disease, is the second one of the top individual cost items for Medicaid budgets is perinatal care, or sorry, NICU care. So I think we're looking at a situation here where I think the economic argument's starting to form. And once that gets settled in, I think we're going to see a fairly rapid progression of interest in this that goes beyond just a side story to actually it is the story.
Well, gentlemen, on behalf of our audience, I'm appreciative of all the work that you both have done and the work that Dental Trade Alliance has done to see where MDI has been, where it's going, and the impact that it could have. So, Dr. Tom Schwieterman, Mr. Ted Kehagias, thank you both for being on today, gentlemen. I really appreciate your time.
Great.
That's great.
Thank you so much, Kevin.
Thank you.
Appreciate the time as well.
Thank you.
Absolutely. Bye-bye. And thanks to all of you for listening to this episode of the Dental Trade Alliance podcast. We'll be back soon with another episode and more information on what the Dental Trade Alliance is doing for its members in the dental industry.